So today we are organizing the 8th online monthly clinical meeting on behalf of WBAP. And here today we will have the participants from Midnapur Medical College. Mentor is HOD of Midnapur Medical College, Professor Tarapada Ghosh. So it's our endeavor on WBAP to reach to everybody. So that's why we have tailor-made the programs in such a way that the Calcutta hospitals will be doing the offline with physical meeting, and in the remote places we'll be doing the online meeting. So this is our 8th online clinical meeting, and this time, after a lot of disturbances and the trouble, I'm indebted to Professor Tarapada Ghosh that he agreed to organize it on 31st of the October so that we can actually complete our schedule in time. So over to you, Professor Tarapada Ghosh, sir, to moderate the session.
Good afternoon, everybody. Good afternoon, Dr. Rai. Shubho Vijay to all. We are really grateful, Midnapur Medical College Department of Pediatrics, because this type of CME, especially for peripheral medical college, is very much important. Because our PGT is often unable to go to Calcutta, as they are very much busy with huge patient load, as also manpower resources less. So anyway, our PGTs are going to present 6 cases. Most of them came to the hospital with some common symptoms like hepatosplenomegaly, short stature, anemia, etc., etc. But they, although with the investigation facilities in Midnapur Medical College and surrounding area, the common investigations are readily available. But sophisticated investigation, uncommon investigation is very much difficult to do here. In spite of that, they tried their best and reached some diagnoses which are very much rare. So, our first case, Dr. Anindya Das will present the case. I am going to start the session. Here also our Midnapur Society of Pediatrics President Dr. P.C. Mondal is also present. He is also associate professor of this institution. So we are going to start the program. Anindya. Huh? Hello, am I audible?
Yes,
Hello?
yes, you are audible and visible also. Please carry on.
Okay, okay. Anindya, share the slide share. Is it visible? Hello, Dr. Roy. Hello. Hello, Dr. Roy.
পরিষ্কার করে বলা হয় যেটা দাদার সাথে মিট করবো এই ঘরে গিয়ে তখন
বলুন স্যার।
হ্যাঁ, শোনা যাচ্ছে?
একদম শোনা যাচ্ছে, বললাম তো শোনা যাচ্ছে। শো করুন এটা।
ওকে, ওকে। হ্যাঁ,
স্লাইড শোতে যান।
হ্যাঁ, স্লাইড শো গেছে।
না, হয়নি, এখানে স্লাইড শো হয়নি, আমরা দেখতে পাচ্ছি না। কালকে তো পরিষ্কার করিয়ে দেওয়া গেল, আজকের কি হলো?
তুই এখানে আছিস? চলে চলে কি একটা সমস্যা হয়ে যাচ্ছে?
If there's any problem, the next one can present the cases.
স্লাইডে যাচ্ছে না ওখানে হয়েছে কাছাকাছি স্লাইড যাচ্ছে না তাড়াতাড়ি এসো। দেখ না কালকে অপর করলি যা কোথায় আছে বা তাড়াতাড়ি তাড়াতাড়ি প্রোগ্রাম শুরু হয়ে গেছে ডিসকানেক্ট হয়ে গেছে ওটা যেটা অনলাইনে কানেকশন হয়ে গেছে কিন্তু স্লাইডটা যাচ্ছে না দেখ না হ্যাঁ?
এবারে ঠিক আছে, ক্যারি অন, শুরু করুন।
যে আমি তো কোনো পার্চেজের
Please continue, please.
Tyrosine type 1 with developmental delay, rickets and coagulopathy. By Dr. Aniruddha Das, third year PGT Department of Pediatrics, Midnapu Medical College and Hospital, Guide Professor Dr. Tarapoto.
স্লাইডের ওপর ডবল ক্লিক করো, মাউসটা নিয়ে স্লাইডের উপর ডবল ক্লিক করো, ব্যাস।
16 months old girl child presented with gradual abdominal swelling and growth and developmental delay. No history of SNC admission, no previous hospitalization. No history of convulsion, syncope, drowsiness, lethargy, feet injury. History of consanguineous marriage was present. The 8-year-old other child appears to be normal. On general survey, baby was alert, conscious. Pallor, cyanosis, clubbing fluids were absent. Neck veins not inward, neck veins not palpable. Vitals were stable. On systemic examination, on DIT examination, moderate hepatomegaly with liver span of 10 cm, smooth surface, rounded border, slightly firm on palpation, non-tender, non-ulcerative. Skin was just palpable. Serious respiratory and CNS examination were within normal limits. On anthropometry, weight for age was at -2 standard deviation on WHO growth chart. Length for age was at -3 standard deviation on WHO growth chart. And mid upper arm circumference was 11.5 centimeters. In WHO growth chart, where there is weight for length plot, it falls on the 0 standard deviation. On weight for age, it falls on the -2 standard deviation. On length for age, it falls on -3 standard deviation. And here circumference for age falls on 0 standard deviation. Developmental milestones, there is gross motor developmental delay of around 5 to 6 months. Fine development is up to date. Language development is lagging behind around 6 months. And there is no social developmental delay. Laboratory investigation, hemoglobin was 8.7 milligram per deciliter. Total amount platelet and peripheral blood sugar was within normal limits. Dietary blood sugar was 66 milligram per deciliter. 12 hour fasting sugar was 60 milligram per deciliter. On AZ analysis, there was no acidosis. On AFP analysis, we have found that HDOT to be mildly elevated. Alkaline phosphatase was also elevated. Total protein and albumin were within normal limits. Serum potassium was found to be on the lower side. On coagulation study, we have found the coagulation study was grossly graded. Protein value was 34.71 second, iron was 2.617 and ABT was 61.69 second. Initial clinical case started. Coagulation profile declared after 5 days, and there was improvement in coagulation studies. Serum lactate, ammonia, and serum lipid were within normal limits. Serum lipid was found on the lower side. USC whole abdomen liquid, hepatomegaly, heterogeneous hepatic structure, no focal display, suggested other insufficient rule of H storage disorder. There was minus megaly erosion. CC whole abdomen liquid, entrance heterogeneous parenchyma, mighty entrance. There was no anything. MRI rate was within normal limits. So due to inherent level of alkaline phosphatase performed APQ of X-ray is right, which repeat size changes. Fraying at the lower end of ulna and cutting at the lower end of the radius. 720 of hydroxyvitamin D was found to be normal limits. 7 phosphorus was on the lower side. 7 RS calcium and total calcium were within normal limits. There was presence of glucose class 2 in the repeat examination. 24 hours usually phosphate would not be same. So we are dealing with an IEM with manually led features, never see normal plasma lactate, normal plasma ammonia, normal lipid profile, and reduced serum uric acid level. So at this point, our differential diagnoses are galactosemia, GSD type 1, GSD type 3, GSD type 6, GSD type 9, GSD type 11, cystinosis, tyrosinemia type 1, and gluconeogenetic type 6. Urinary non-glucose substance was absent, so galactosemia is ruled out. Urinary erythropoiesis was absent, so GSD type 9 and gluconeogenetic type 6 is ruled out. Normal serum lactate, normal lipid profile, reduced serum uric acid, GSD type 1 is ruled out. Normal urinary index, absent urinary ketone body, absence of bilirubin, so GSD type 3 is ruled out. Now the differential diagnosis are GSD type 6, GSD type 11, cystinosis, tyrosinemia type 1. Among these four differential diagnoses, family fetal syndrome, cystinosis, and tyrosinemia type 1 have fetal family fetal hepatic involvement. Serum succinylate acetone level was found to be elevated. We have seen clinical exam sequentiality recognize autosomal recessive as KPH because vitamin lagging ability. So our diagnosis is tyrosinemia type 1, also known as hepatic tyrosinemia. We have seen serum alpha fetoprotein, and it was found to be grossly elevated. Serum delta aminolevulic acid, serum tyrosine level, and serum urine level was planned to be done in subsequent visits. So we have started the treatment in the form of vaccine mixture. We have performed slit lamp ophthalmological examination, which was found to be normality before starting medicinal, in an allergen and tyrosine restriction, phosphorus supplementation, and calcium supplementation for 2 days. Thank you.
So, you could start. So, am I audible? So it is a important case. It is a rare case. It is a tyrosinemia type 1, and the most important investigation is the one we have done genetic study, as also the succinylate acetone. And the child is getting it, and we are following the child, and the child is also improving. And tyrosinemia type 1, usually most of the patient is present in the first year of life. Usually some hepatic problem and subsequently some renal tube problem. And some may have also have some neurological problem. So our patient usually presented with some features of BPS as also grossly different PTAPT. If the grossly different PTAPT and allowed alpha fetoprotein level is high, so one can suspect it. So thanks for Aniruddha. If there is a question from audience. Our second case we are going to present the second case.
Support.
Good afternoon, respected delegates. My topic is silent invader, genitourinary tuberculosis unveiled. So, chief complaints: 10 years old male child, resident of Paschim Mednipur, came with complaints of dribbling of urine since 2 weeks, increased frequency of micturition since 2 weeks, and scrotal pain and swelling since 5 days. The patient was apparently well 5 years back when the patient started experiencing burning sensation while micturition along with fever. The patient was diagnosed as urinary tract infection by a local doctor, where he was treated with antibiotics. Urine report at that time was pus cells plenty and RBCs plenty. Similar complaints were noticed weeks later, and he was admitted to a subdivisional hospital where a diagnosis of posterior urethral valve was made and was treated with antibiotics, and the patient was referred. Later, the patient was admitted in MMCH with similar complaints and one episode of painful hematuria. There was no history of back pain or flank pain. There was history of surgery 2 years back for posterior urethral valve. There was no history of anorexia, night sweats, or weight loss. There was no history of anasarca. There was no history of contact of TB in family. There was no significant perinatal history. The patient was given tablets fixing for 14 days, 1 month back. At that time, the USG was suggestive of posterior urethral wall. So the patient had undergone POV laser fulguration surgery under general anesthesia at NRS Medical College in 2020. Later, the patient was discharged and followed up at NRS Medical College, but no improvement was seen in symptoms. And even on urine RMA report, it was same as that of earlier. That is, pus cells were plenty and RBCs were plenty. The developmental history, like developmental milestones, were achieved appropriately as per age. The immunization was completed as per national immunization schedule. The BCG scar was present. The patient belongs to the upper lower class, socioeconomic class. There was no history of tuberculosis in the family and no protein or calorie deficit was there. On general survey, the patient is conscious, alert, oriented to time, place, and person. The patient is well built with normal facies. The patient had mild pallor but no lymphadenopathy. Pulse was 84 per minute. Respiratory rate was 17 per minute. Blood pressure was 128/82 mmHg, and the patient was afebrile. On head-to-toe examination, swelling over the scrotum was present, along with a hypopigmented firm nodule since 1 week. Annular ring-like lesion was present over the medial aspect of the right thigh, which was most likely tinea. So from the above clinical history, we examined the genitourinary system first. On examination of the kidneys were not palpated by bimanual palpation, and no renal angle tenderness was present. On examination of the hypogastrium, there was a rounded swelling over the hypogastrium with no erythema and redness was noted. And after emptying the bladder, the swelling was not visible, and on palpation, there was mild tenderness as well. And on examination of the genitals, there was swelling over the right side of the scrotum, which was reddish with slight tenderness. It was trans-eliminable and was able to get above the swelling. Bilateral testes were palpable in the scrotum and the Prehen's sign was positive. All other system examinations were within normal limits. So from the above clinical history and systemic examination, the differential diagnosis for this case are architis, epididymitis, bladder bowel dysfunction, cystitis, and genitourinary tuberculosis. So we'll move towards the investigations. The hemoglobin was 8.4 gram%. The renal function tests were within normal limits. The electrolytes were within normal limits. And the first urine RMA report after admission was taken on 10th of July, which was albumin 2+, pus cells plenty, RBCs plenty, but the culture showed no growth. So the patient was started on empirical antibiotics, that is third generation cephalosporin and aminoglycosides. But after 48 hours of follow-up, there was no improvement seen in the patient symptomatically, and even on urine report, which was repeated on 17, it was albumin, which was 1+, pus cells were plenty, RBCs were plenty, and again we can see over here, the culture was again no growth. So at this time, the third generation cephalosporin was replaced with the imipenem group of drugs, that is meropenem, along with aminoglycosides. And after this, we again followed up the patient after 48 hours. There was no improvement symptomatically. And we can see over here, again, the repeated urine RMA report was pus cells plenty, RBCs were plenty, culture again showed no growth. So we proceeded towards the next investigation, that is USG of the kidney and the urinary bladder, which was suggestive of chronic cystitis and bilateral moderate hydroureteronephrosis. And the USG of the bilateral inguinoscrotal region showed microlithiasis, which was suggestive of bilateral chronic orchitis. And there was anechoic collection in the bilateral epididymis, which was suggestive of bilateral epididymitis. And there was right-sided mild hydrocele as well. On micturatic cystourethrogram, we can see over here, there was grade 3 vesicoureteric reflux with multiple circulations in the bladder. We further did the technetium-99 DMSA renal scan, which we can see over here. The left kidney appears to be hydronephrotic, and there is cortical scar over the left-sided kidney at its lower pole. And the right kidney showed normal cortical function. The differential function of the left kidney was 22%, and the right kidney, it was 78%. So as the above investigations were suggestive of chronic infectious etiology, and the possibility of tuberculosis cannot be ruled out, even if there was no family history or a contact with TB patient. So we performed a Montu test, which came out to be negative, but the urine for CBNAT, it was detected as positive. The chest X-ray and sputum for CBAT was also done, but it was within normal limits. So points in favor of my diagnosis were recurrent urinary tract infection, not responding to full course of antibiotics, scrotal pain and swelling for around 2 weeks, and imaging studies suggestive of chronic infectious etiology. A diagnosis of genitourinary tuberculosis, that is bilateral TB orchitis with left-sided grade 3 vesicoureteric reflux with chronic cystitis was made. So the patient was started on anti-tuberculosis treatment, that is 4 pediatric FDC along with ethambutol and tablet pyridoxine. And the patient was sent to NRS Medical College for urology opinion, where the patient was asked to follow up every month. Then we discharged the patient with the same anti-tubercular ATT management along with follow-up. After 1 month of follow-up, we observed that their swelling was reduced to almost normal. There were no further episodes of fever, burning micturition, and dribbling of urine was noted. And you can see over here the repeated urinary EMA report. It was albumin nil. Pus cells came down to 10 to 12 pus cells per high power fit, and even the RBCs were decreased to 2 to 3 RBCs. So there was clinical improvement as well. And again, we followed up the patient after 1 month. We can see the patient was symptomatically fully recovered, and even the urine RME report, it was within normal limits. So summary was that 10 years old male child complaining of dribbling of urine, increased micturition, scrotal pain, and swelling with recurrent hospital admission for urinary tract infection, not responding to antibiotics. And above supporting investigations suggestive of chronic infectious etiology implicate the need to rule out tuberculosis, which is very much prevalent in a developing country like India. Thank you so much.
I've got a question. Why have you started meropenem and amikacin?
Sir, actually,
What microorganism will not be taken care of by the meropenem and it will be taken care of by the amikacin?
actually, sir, amikacin basically take care of the gram-negative organisms, and meropenem, sir, has a broad spectrum, which includes gram-positive, gram-negative, as well as anaerobes, sir.
So why have you added? Because if you give meropenem, it is enough to cover up everything.
Sir, it is.
Finally, the case was diagnosed to be tuberculosis.
Sir, actually,
Vesicoureteral reflux, right?
Actually, the problem is that there is huge number of parcel as also there is RBC. So it may be of renal calcium origin, or it may be some cystitis from there. So in that cases, it is a little bit unusual, because as the patient is not responding, it is just on trial and error basis they have given. But actually, the problem is going on for last 5 years, and unfortunately, there was stricture formation, I think, in the urethra, and that led to misdiagnosis that there is a posterior rectal valve. Actually, initially it is the renal parenchyma, I think it was involved, and subsequently whole of the urinary system, as also the genital system also involved. And renal parenchyma involvement followed by I think there is ureteric involvement, bladder involvement, as also typically the involvement. So, Dr. PC Mondal.
So actually, the meropenem has got a very good serum penetration. The MIC value is quite high. If only problem in meropenem cannot go within the CSF. It is about 1/8 of the concentration what you find in the CSF. So only for that cases where you are suspecting meningitis, you can add on amikacin on top of the meropenem. But actually, if meropenem is given the dose 40 milligram per kg per dose 3 times a day, it jolly covers all the organism that is present. Your patient child was having a kidney disease, and you were
Actually, patient is a chronic patient. The patient had received repeated episode of antibiotic before admission.
So thinking that why the patient is not responding, that too by several antibiotics, it has some impression was that the organism which is creating the problem maybe resistant to the antibiotics which the patient receives outside. So in that way, thinking that we should combine that antibiotic where the patient must respond. If the meropenem is not sensitive, then amputation will do. In that way, you combine that. But the common teaching is that any patient which is a chronic presentation and where there is presence of partial and RBC and that is not responding in any way by repeated episode of antibiotics, that the message is that it must be something else other than common bacteria, maybe resistant organism or straightforward, maybe tuberculosis. So in that way, investigate the patient and ultimately got the result. Purpose of giving combination of the antibiotic because the patient received repeated episode of antibiotic outside. So if we gave only meropenem and after that we did not get any response, we may think that that organism is resistant to meropenem. That's why the combination of these. But you are right actually that only meropenem may be suffice. So we are going to present the next case.
Thank you so much, sir. A very good afternoon to everyone. My topic is a confusing encounter with hereditary spherocytosis. My patient Dia Mahato, born out of non-consanguineous marriage, presented at 6 months of age with complaints of intermittent nasal discharge for 5 days, occasional bouts of cough for 3 days, and gradually increasing paleness since last 1 month. Cough was without expectoration and serous nasal discharge and were not associated with fever or any respiratory distress. There was gradually increasing paleness since last 1 month, associated with irritability. There is no history of bleeding manifestations, no history of yellowish discoloration of sclera or urine, no history of any recent drug intake, no history of recent weight loss, and no family history of anemia, jaundice, gallstone, or any hemoglobinopathies in the first or second degree relatives. No significant past medical history, one sibling 6 years of age, but no significant medical history. Antenatal history was uneventful. There is no history of neonatal jaundice. Child is exclusively breastfed and complementary feeding is not yet started. And developmental history and immunization history was normal. On clinical examination, child was irritable, pulse rate was increased, there was severe pallor, icterus was absent, lymphadenopathy was absent, facies was normal, there was abdomen, shows no hepatosplenomegaly. Anthropometry showed underweight, grade 1 Gomez classification and mild malnutrition. Investigations at this point, CRP was normal, hemoglobin was severely decreased, 3 gram per DL, total count, platelet count was normal, total erythrocyte count was decreased, RDW was increased, reticulocyte count was corrected was normal, and Mentor's index was greater than 30. Peripheral blood smear shows microcytic hypochromic picture, few polychromasia, anisopoikilocytosis, WBC and platelet counts were normal and no abnormal cells were present. Mother and father HPLC was normal. Chest X-ray, urine examination, renal function and liver function tests were absolutely normal. Child received Paxil blood transfusion and the hemoglobin was increased to 8 gram per DL. So at this point, the provisional diagnosis was upper respiratory tract infection with nutritional anemia. The points in favor were no complementary feeding was started, there was mild malnutrition, no icterus, no hepatosplenomegaly, no family history of anemia, microcytic hypochromic picture, and there was RDW was raised and reticulocyte count was normal. Mender index was greater than 13 and parents HPLC was normal. So the child was discharged with oral elemental iron and review after 2 weeks. And differential diagnosis at this point was pure red cell aplasia, transient erythroblastopenia of childhood, diamond Blackfan anemia, hypoclastic crisis in a case of hemolytic anemia, anemia of chronic disease, sideroblastic anemia. Confusion arising at this point was why hemoglobin was severely low in a nutritional anemia, why there was polychromasia. 3 weeks after discharge, the hemoglobin was again severely low. Child was hemodynamically stable,
So there, at this point, we had a high suspicion of alternate cause of anemia. So iron was continued and child was asked to review with peripheral blood smear, iron profile and LDH after 1 month. At 8 months, there was no fresh complaints. At this time, pallor was present, severe. Icterus was nil, but at this time, the splenic tip was palpable. Rest of the examination was normal. On investigations revealed, hemoglobin has severely decreased. RDW was raised. Peripheral blood smear changed from microcytic hypochromic to normocytic hypochromic. Reticulocyte count was increased. Total bilirubin, serum ferritin and serum iron was increased. LDH was in the normal limits. So provisional diagnosis based on the reports was changed to chronic hemolytic anemia because the reticulocyte count was increased, mild splenomegaly was there, increased total bilirubin was there, and there was increased iron and ferritin levels. So oral iron was stopped at this moment, and further investigation were sent to find the cause of hemolytic anemia. So further workup showed parents' HbA1c was normal, so hemoglobinopathies were ruled out. G6PD level of normal, so G6PD deficiency was ruled out. Other enzymopathies, which generally presents with chronic non-spherocytic anemia, less likely since majority of them have history of neonatal jaundice. Mother and child blood group was similar, O positive, so ABO incompatibility was ruled out. There was no fever, malaria test was negative, so hemolytic anemia due to malaria was ruled out. Direct Coombs test was negative, so autoimmune hemolytic anemia was ruled out. There is no history of hemoglobinuria or pancytopenia with thrombosis, so PNH was ruled out. And peripheral blood finding was not suggestive of any membrane defects. So direct osmotic fragility test was sent since it was very cost effective. So the direct osmotic fragility test came out, it showed increased osmotic fragility, and this shows the curve shows a right shift in the osmotic fragility curve. This is the actual report. And the differential diagnosis after the osmotic fragility curve changed to hereditary spherocytosis, hereditary stomatocytosis, and hereditary pyropoikilocytosis. G6PD deficiency, autoimmune hemolytic anemia, and ABO incompatibility also shows increased osmotic fragility, but these were ruled out earlier. Since peripheral blood smear did not show any spherocytes or elliptocytes, patient was planned for clinical exome sequencing. Finally, clinical exome sequencing report came. A heterozygous missense variant in exon 20 of beta spectrin gene was detected. It was diagnosed to be a case of hereditary spherocytosis type 2. Treatment was started. Child was started on folic acid supplementation, blood transfusion as and when required, regular monthly follow-up on OPD basis for growth monitoring, proper parenteral counseling was done, parenteral gene testing was advised, and spleen size was monitored via USG. So diagnostic algorithm for this case was, first the patient was diagnosed as nutritional anemia, but the doubt still continued. We sent for repeat examination where it was changed to chronic hemolytic anemia. And the direct osmotic fragility narrowed down our diagnosis. But since RBC defects could not be found out in the peripheral blood smear, genome was sent, which finally diagnosed as a case of beta spectrin gene mutation, hereditary spherocytosis type 2, which is a rare case. In the literature, there are 2 cases reported of hereditary spherocytosis type 2, both having a history of neonatal jaundice. In a study conducted in the China also showed that the clinical diagnosis of hereditary spherocytosis is challenging due to high phenotypic variability. It has non-specific indicators. Therefore, it should be endeavored to actively improve the application value of gene detection technology in the diagnosis of hereditary spherocytosis. Even Nenson has marked that by that HSC hereditary spherocytosis is marked by wide variability in associated clinical laboratory and genetic manifestations. So confusions during this case which was noticed where why at the first visit there was no features of suggestive of hemolytic anemia. Was the severe anemia in the beginning due to hypoplastic crisis, due to masking effect of a nutritional anemia upon hemolytic anemia? Was the blood picture in the beginning masked due to nutritional component? There was no family history of anemia, no neonatal jaundice, no spherocytosis on PBS, and MCHC levels were normal. Still, it was diagnosed as a case of hereditary spherocytosis. And why did the baby require frequent blood transfusions, even though the beta spectrin gene mutation disease severity is mild to moderate? So the discussion point is the initial episode can be due to hypoplastic crisis due to infections, though parvovirus testing was not there at that moment. And infants are typically slow to mount adequate reticulocyte response. Therefore, blood picture may alter. Therefore, need for frequent transfusions in infancy is not indicative of severe disease later in life. Iron deficiency may correct the laboratory values, but not the red cell lifespan in hereditary spherocytosis patient. Even folic acid deficiency can mask the blood picture. Hereditary spherocytes present with wide phenotypic variability in clinical lab, and this case is a typical example of it. So the learning points from this case scenario was severe anemia in infancy should always be investigated for pathological causes. Blood picture is a non-specific indicator in hereditary spherocytosis. Clinical diagnosis can be challenging due to wide phenotypic variability. Genetic studies should be considered to bridge this gap, and genetic studies can expand the mutation spectrum of beta-spectrin gene. And finally, the severity of hereditary spherocytosis cannot be ascertained in infancy. My limitations were the bone marrow was not done, iron profile was not done in the beginning. Very few cases of beta-spectrin gene mutation has been reported in literature. Parvovirus B19 susceptibility or immunity was not documented. These are the references. Thank you.
Second presentation.
This is one of the excellent case that you were showing. I just want to know, in Midnapur, have you got the facility of doing this a whole exome sequencing, or you send it to Kolkata?
No, actually it is not done here. The outsourcing is done. Some people used to come here and they have the phone number. And actually they used to come and take certain. It's not done
So,
here.
and what is the? It is done from Kolkata.
মেডজেনোম আছে, তারাই কলকাতায় স্যাম্পল দিয়ে গিয়ে টেস্টিং
Okay.
ফর জিন সিকোয়েন্স।
And what is the price of osmotic fragility test, and what is the price of whole exome sequencing by the next genome?
So osmotic fragility test was around 1200 to 1300, and the whole genome test clinical exome was around 12,000.
And whole exome?
Whole exome is about 18,000.
Okay. Okay.
Any question?
So,
Yes,
Tarapada, we can move on to the next case.
Thank you.
In HLH, also think of common ailments. Myself, speaker is Dr. Ayodhya, third year PGT, Midnapur Medical College, and my guide is Dr. Sunil Kumar Hebram, Associate Professor. My patient came with chief complaints of fever for 12 days, gradual swelling of abdomen for 5 days, and respiratory distress for 3 days. Fever was of 12 days back, and it was of high grade and remittent. Swelling of abdomen was for last 5 days, which was also insidious in onset and gradually progressive. Respiratory distress was also for 3 days before admission, and it was also insidious in onset and gradually progressive. No history of burning sensation during micturition, pain abdomen, convulsion, and any bleeding manifestation. No history of petechial spots or rashes or decreased urine output or yellowish discoloration of skin. There is nothing significant in past history. In antenatal birth and developmental and immunization history is also normal. There is no abnormality detected in those histories. So, according in socioeconomic history, patient belongs to upper lower class as per modified Kupuswamy scale. There is no family history suggestive of the complaints of the patient. In dietary history, patient was exclusively breastfed for first 6 months. Then complementary feeding was started. Protein and calorie intake were adequate. In general examination, patient is conscious but irritable and sick looking. Temperature was 102 degree Fahrenheit. Respiratory rate was 48 per minute, and heart rate was 140 per minute. Other vitals were stable. Patient has mild pallor, no icterus, no cyanosis or clubbing. Swelling of abdomen without facial head-to-toe examination, there is swelling of abdomen without facial puffiness or pedal edema. Eschar mark near left axilla noted. In systemic examination, gastrointestinal system was examined first. Mild swelling of abdomen without shifting dullness or fluid fill, moderate hepatosplenomegaly. In respiratory system, there is moderate respiratory distress with respiratory rate of 48 per minute. Right-sided air entry is diminished in lower lobe. Crepitations were found. Other systemic examinations were within normal limit. Up to this point, we have got the following differential diagnosis, that is Craft typhus, dengue, severe malaria, pneumonia, enteric fever, UTI, and septicemia. Now the investigations, there is hemoglobin was 7.4, total count was 24,800, and platelet count was 30,000. PCV was 22.7, that is diminished, and ESR was 8 millimeter. CRP was 30.9, X-ray showing patch in the right lower lobe near heart border. In fever profile, dengue, IgG and IgM, scrub IgM were negative. Vital was positive in aggregation up to for S-type-O in 1:320 dilution. Liver function test was deranged. Enzymes levels were elevated. Conjugated bilirubin was 1.9 and unconjugated was 1.07. Serum urea, creatinine, sodium, potassium were normal. Urine REME were also normal. Blood cultures and urine cultures reports were awaiting up to this point. Treatment and course of history: from history, clinical examination and laboratory findings, enteric fever with pneumonia and hepatitis have been found. Patient was put on IV antibiotics, ceftriaxone and azithromycin and antibiotics and other supportive measures. Clinically, no response, developed shock and bleeding spots. Blood culture and urine culture came negative till now. Now, we have repeated CBC with peripheral smear. There was one microcytic hypochromic anemia. Platelet count was further reduced to 15,000 and hemoglobin was 5.6 gram per TL. Treated with component transfusion. Due to bicytopenia as well as persistent of fever and progressive poor condition of the patient, we thought about the further diagnosis of HLH, DIC, MISC, and septicemia with impending MOTS. Serum for scrub typhus antibody was again sent as SCR was found, but it was found again negative. Further investigation from inflammatory disorders were considered. PT and APTT were elevated. INR was 1.9. Serum ferritin was more than 2000 nanogram per TL. D-dimer was 3.15 microgram per 6-fold raised. Triglyceride was 271 milligram per TL. LDH was 650 units. COVID, IgG and IgM were negative. Planned for bone marrow examination, but as the patient was going on shock, so it was not possible. Now, for the final diagnosis, we have matched with the HLH criteria, that is of 2004. We have found 5 positive findings, that is fever was present, splenomegaly was present, cytopenia, bicytopenia was present, and triglyceride was more than 265, and serum ferritin was greater than 500. Soluble CD25 and NK cell cytotoxicity was not done. So the final diagnosis, considering all the facts and laboratory reports, it's going to be a case of secondary hemophagocytic lymphohistiocytosis, probably triggered by Salmonella typhi. Treatment was started according to HLH 2004 protocol. Injection dexamethasone was given. On the next day, fever frequency diminished, but shock decompensated. There are few cases in the there are some cases in the literature that HLH secondary to enteric fever. So take-home message is fever not subsiding after instituting all measures for the possible diseases should have to look for the unusual causes. Investigation for the unusual causes should be done promptly. Thank you.
In terms of interesting test, Dr. Rai, is there any question?
Have you done the ferritin, serum ferritin level?
Yes, sir. It was more than 2000.
More than 2000.
More than 2000. Okay.
Actually,
Secondary
it was-
HLH is very common, and here it is due to the enteric fever. It is very common. In ICH, we have a lot of HLH patient and the highest raised in the eastern region. Anyway. Okay. So, what treatment you have given? Only Dexa?
Only dexamethasone was started, and from the next day onwards, actually, patient was the shock was decompensated, and we have also planned to start etoposide and the cyclosporine, but that was not possible. That's the patient expired on the next day.
So, for how many days you have given the steroid?
Actually, we have got for 1 day,
Just 1 day.
just 1 day.
But it is not the protocol of treating HLH with steroid for 1 day because
No,
I
patient
have
has
that,
patient has expired, sir, actually.
expired. Okay.
Patient expired within 24 hours.
Instituting steroids, patient has died within 24 hours. So that's why we have able to give only 1 single doses actually. We have planned for 8 weeks, but we couldn't give it.
Now, whether you used to give a cyclosporine and etoposide, etc., and ICH, that is also not available here.
Yeah, we have given. Our first case was Srija Rai Chaudhary, I have told the other day, and she was being taken next to Vellore, and they have given a protocol of giving these cyclosporine and etoposide, and child is now doing well. That was our first case, and at the time in the initial bone marrow we didn't get the hemophagocytes. So I requested Dr. Devashish Banerjee, Rai and Trivedi, you do it again. And then the second bone marrow, we got the hemophagocytes. So this is possible. This is possible. And another thing is in secondary HLH due to infection, if you just take care of the primary disease, it abates. But it was very unfortunate that the child went into a decompensated shock and we lost the child. Anyway,
Your case also.
good diagnosis. So we can move on the next.
Okay.
Tarabodada.
Immunity causing yellow baby. Speaker Dr. Sundeep. Immunity causing yellow baby. Speaker Dr. Sundeep বিশ্বাস. Writes Prakash Chandra Ghosh sir. Chief complaint: 6-year-old male patient parented with Midnapur Medical College and Hospital with complaint of fever for 10 days, yellowish discoloration of eyes and body surface for 8 days, dark color urine for last 7 days, and itching all over the body for last 7 days. The child was apparently well 10 days ago. Then he developed high-grade intermittent type of fever. Yellowish discoloration of eyes and generalized body surface was sudden in onset and gradually progressive. Dark color urine and itching all over the body for last 7 days. There is no history of vomiting, abdominal pain, loss of appetite, gum bleeding, melena, or hematuria was present. There is a history of waxing and waning of similar type of illness for the past 2 years, but the child did not visit any nearby hospital. There is no similar illness in his family. The child born with normal vaginal delivery at term. Birth weight was 2.1 kgs. The child cried immediately after birth. There is no history of SNCU admission. All the developmental history, all the developmental milestones were achieved as per age in terms of motor, sensory, and language development. Immunization history: when child was fully immunized as per age according to NIS. Dietary history: the child was exclusively breastfed up to 6 months. Then complementary feeding was started. Now the child is feeding from family pot with adequate intake of calorie and protein. Socioeconomic history: the family lives in Kacha house with separate kitchen, toilet, and drinking water source. The family falls in lower socioeconomic class according to modified Kupuswamy scale. General survey shows the child was alert, conscious, and oriented to time, place, person. Child was had severe pallor and severe jaundice, but there is no cyanosis, clubbing, or edema was present. Heart rate was 112 per minute, and BP was 102 by 56 millimeter of mercury. Temperature was 101.6 degree Fahrenheit. Local examination was normal. Systemic examination, GI system examination shows liver was palpable 3 cm below the right costal margin in the mid clavicular line. Liver span was 7 cm firm in consistency, surface smooth, sharp margin, no tenderness was present. Spleen was palpable 2 cm below the left costal margin in spino-umbilical line. There is no ascites, tenderness present over the abdomen. Other systemic examination was normal. At this point, the differential diagnosis will be acute viral hepatitis due to Hep A and Hep B infection, chronic viral hepatitis due to Hep B and Hep C infection, autoimmune hepatitis, overlap syndrome like primary biliary cirrhosis and primary sclerosing cholangitis, metabolic disorder like Wilson disease and alpha-1 antitrypsin deficiency. Investigation: complete hemogram shows hemoglobin 7.2 gram%. Peripheral blood smear shows microcytic hypochromic anemia, marked anisocytosis. Corrected reticulocyte count was 3.8%. HPLC sent, which comes normal. Liver function test shows total serum bilirubin was 14 milligram per TL. SGOT, STBT was highly raised. GGT was raised. Total protein was 7.6 gram per TL. Albumin and globulin ratio was altered. Coagulation profile is highly deranged. Renal function test was normal. Malaria, dengue, and scab IgM was sent, which comes negative. We sent at this point the LFT size tip of hepatitis. So hepatitis A IgM and hepatitis E IgM antibodies sent, which comes non-reactive. HBs AG and anti-ACV sent, which comes non-reactive. Leptospira IgM non-reactive. USG whole abdomen shows liver enlarged 11.72 centimeter. Spleen was 9.4 centimeter enlarged. Portal vein was 8 millimeter. No thrombosis is visible. Size USG size tip of chronic hepatitis. At this point, acute and chronic viral hepatitis was ruled out. So it proceed for further investigation to rule out metabolic or autoimmune causes. 24-hour urinary copper was sent, shows mildly elevated. and serum ceruloplasmin was normal. Eye examination shows no KF ring. So we sent autoimmune hepatitis marker. NA-HEP2 was sent, which comes positive in 1:100 titer. Serum IgG was sent, which shows 1.1 more than upper limit normal. Hepatitis marker was negative. We used the simplified autoimmune hepatitis code and liver. At this point, the point was 5. So liver biopsy was done. Liver biopsy shows proliferation of the bile ductules with interface hepatitis and marked cholestasis, and the score was 7, which suggestive of definite autoimmune hepatitis. So my final diagnosis would be overlap syndrome or primary sclerosing small duct primary sclerosing cholangitis with autoimmune hepatitis was made. The child was treated with PRBC transfusion, VT injection, FFP transfusion, and TAP ursodeoxycholic acid. After diagnosis, the child started oral prednisone at 2 mg per kg per day and continued for 3 months till the liver enzyme came back to twice the upper limit normal. After that, the steroid tapering was started, but the child developed steroid toxicity. So we start azathioprine at 1.5 mg per kg per day with alternate day steroid. After 5 months of treatment, liver enzymes came back to normal and the size of the liver also reduced. The child was also advised for fecal calprotectin and colonoscopy to rule out IBD, but due to some financial reason, parents were unable to do that. Take home message: suspect autoimmune hepatitis as a cause of acute or chronic hepatitis, when other cause such as viral, metabolic, or cholestatic drug induced, this has been excluded. Immunosuppressive therapy should be instituted in patient with serum AST or ALT level greater than 10-fold upper limit normal. Autoimmune hepatitis must also be suspected because early treatment can reduce mortality and progression of cirrhosis significantly. Sorry.
So it is also an interesting case. Actually, there are type 1 and type 2 type autoimmune hepatitis. And unfortunately, some antibody titer not done. At least anti-LKM antibody as also that of the liver soluble antibody. So that are not done, but there is a simplified scoring system. You use that scoring system, and that falls under autoimmune hepatitis. So patient also responded. It's also a good case. So if you have got any question from audience.
Actually, there is no question, but the previous speaker had several questions. So we'll ask at the last. Okay. Dr. Rupa Bishas and Dr. Ajay Raghav has asked few questions. So we'll take up later at the end of the presentation.
Completing the question.
Okay. So next speaker, please.
Good afternoon, everybody. A dwarfing dilemma: navigating the enigma of isolated growth hormone deficiency by Dr. Hamad Mullah under the guidance of Dr. Prabodh Chandra Mondol, Associate Professor, MMCH. Chief complaints: a 5-year-old male child, second in birth order, born out of non-consanguineous marriage, resident of West Midnapur, informant being mother, presented with chief complaints of not gaining adequate height and weight since 2 years of age. History of present illness: parents noticed that their child is not growing in adequate height and weight since 2 years of age. He is short when comparing to others, boys and peers, children in the same age group. Weight gain is also low when compared to the other children. There is no history of mental apathy, irritability, inadequate dietary intake, weight loss, diarrhea, steatorrhea. No history of polyuria, oliguria, polydipsia, exercise intolerance, palpitation, shortness of breath, cyanosis, cough, and recurrent respiratory tract infection. There is no history of lethargy, constipation, cold intolerance. No history of headache, vomiting, visual disturbance, bone deformity, recurrent fracture. But the history, there is history of delayed dentition was present. Past history: there is no significant past history, and antecedent history was also not significant. Birth history: the child is delivered. The child is delivered by cesarean section sector with birth to 3 kg. There is history of delayed cry, for that requiring resuscitation. Postnatal history: there is history of SNCU admission for birth asphyxia and neonatal sepsis and hypoglycemia for 10 days. Developmental history. All the developmental milestones were achieved appropriately as per age in all the domains. Immunization history. The child is immunized completely as per national immunization schedule. Nutritional history. Delayed onset of breastfeeding, exclusively breastfed till 7 months of age. Complementary feeding was started after 7 months of age. He takes mixed diet and calorie and protein intake is adequate. Family history. There is no significant history of illness in the family. Mother is short stature and mother height is 138 centimeter. Father height is 151 centimeter. Mid parental height is 151 centimeter. First child is 7 years old, developmentally normal and taller than the sibling. Socio-economic history. The child belongs to upper lower class family according to modified Kokusumi scale. Anthropometric. Weight is 7.7 kg, that is less than 3rd percentile according to IP growth chart. Height is 76 centimeter, that is also less than 3rd percentile according to IP growth chart. Upper segment, lower segment ratio 1.2:1, that is normal and proportionate. Mid parental height is 151 centimeter, that is also less than 3rd percentile. This shows the WHO 2006 and IIP 2015 combined growth chart for boys 0 to 18 years of age. The upper one shows the height for age, that is less than 3rd percentile, and lower one shows the weight for age, that is also less than 3rd percentile. And on the left side, there is mid parental height, that is also so less than 3rd percentile. Head to toe examination. There is sparse hairs, frontal bossing, doll-like faces, short neck, delayed dentition, high-pitched voice. No skeletal abnormalities, no kyphoscoliosis. And there is micropenis. Stress penile length was 3 centimeter. On general examination, the child is conscious, alert, and cooperative. No pallor-icterus, cyanosis, clubbing, edema, lymphadenopathy. Vitals was within the normal limit. And all the systemic examination was within the normal limit. Differential diagnosis of short stature, familial short stature, constitutional delay in growth, nutritional short stature due to chronic systemic illness, hypothyroidism, Cushing syndrome, growth hormone deficiency, syndromic short stature like Down syndrome, Noonan syndrome, Prader-Willi syndrome, achondroplasia, rickets, primordial dwarfism, and psychosocial dwarfism. Summary. Here's a 5-year-old male child born out of non-consanguineous marriage with history of essential admission due to sepsis and hypoglycemia and birth asphyxia with normal development, with short stature noticed since 2 years of age, with delayed dentition, with no significant chronic systemic illness. On examination, there is phenotypic features of growth hormone deficiency like frontal bossing, sparse hairs, delayed dentition, high-pitched voice, doll-like faces, proportional pathological short stature, severely stunted with micropenis with no evidence of systemic illness. Laboratory investigation. Complete blood count shows complete blood count was within normal limit. ESR CRP was also within normal limit. Peripheral blood pressure shows normocytic, normochromic, and no abnormal cells was seen. Routine urine analysis was also normal, and fasting blood sugar was 50 mg per deciliter. Renal function test and liver function test was within normal limits. Serum calcium was 8.5 mg per deciliter, serum phosphorus 5.2 mg per deciliter, 25 hydroxy vitamin D3 24.8 nanogram per deciliter, that was low. X-ray of the left hand with wrist joint, AP view, which shows the appearance of capitate bone, appearance of the capitate, hamate, and tricutral. So bone age is about 2 years. And at this point, chronological age, that is 5 years, more than the bone age 2 years, more than the height age 1.2 years. Thyroid profile. FT4 and TSH was within normal limit. Serum cortisol was within normal limit. Plasma ACTH is also within normal limit. Insulin-like growth factor 1 level, IGF-1 level was very low, that is less than 15 nanogram per ml, and insulin-like growth factor binding protein 3 level, that is 1.8 microgram per ml, that is also low. And growth hormone stimulation test was done, which shows the subsequent result at 30 minutes, 60 minutes, and 90 minutes, all are very low. MRI brain with pituitary, MRI brain and pituitary gland with contrast was done, which shows no gross abnormality. And diagnosis, considering history, examination, and all the above investigation, are diagnosis of pathological short stature with isolated growth hormone deficiency was made. Treatment. Recombinant human growth hormone was started at a dose of 0.1 unit per kg per day in subcutaneous route, and vitamin D3 was also given, that is 60,000 large doses, that is 60,000 in international unit per week, given orally for 6 weeks. And calcium supplementation was also given for given at a dose of 600 mg per day, and then serum vitamin D3 600 international unit per day, and high protein diet was advised. Follow-up. Growth monitoring done every 3 monthly. Height increase in 6 to 6 centimeter and weight increase to 1.3 kg in last 6 months. On the left side, the graph shows the upper one, that is height for age. That is also less than 3rd percentile, but the height is increased to some extent in the last 6 months after taking the recombinant human growth hormone therapy, and weight is gained to some extent, increased to some extent. Take home message: growth hormone deficiency is a rare cause of short stature. Close monitoring of growth is an important indicator of general health and easily accessible to any clinician. An early diagnosis and quick initiation of substitution treatment gives the patient the chance of an excellent prognosis regarding growth potential. Thank you.
So it was an excellent case, and the main thing that you have given in the take-home message is that early diagnosis and initiation of the treatment, because the child was 5 years and old, and you have started much earlier. So I think prognosis will be better. May I take few of the questions, Tarapada? May I take questions? So Dr. Rupa Biswas has asked, particularly in this case, what is the upper segment, lower segment ratio?
Which case? In this case?
In this case.
1.2 by 1.
1 point.
1.2.
So 1 is 1.2 is to 1. That is normal and proportionate at this age. The age of the child was 5 years.
This 1.2 is to 1.
Oh. There was other questions also. What is IGF and IGF BP?
Hello.
Did you get the question? Where do you test IGF and IGF BP?
That is good.
Outside.
There is a laboratory called Spondon. They have also some outside. There's a big lab. There's a big laboratory. They used to take the sample and do it from outside. Spondon is done from Spondon.
So there are a lot of questions in the previous case. The child with HLH. How many days ceftriaxone was given prior to dexamethasone? It was again by question asked by Rupa Biswas. For how many days you have given ceftriaxone before starting this DEXA?
Actually,
It is not your case.
Actually, the patient got admitted 5 days for 5 days, and he was receiving ceftriaxone from the day 1. I think that was he received ceftriaxone for 5 days, and on the patient admitted almost with multi-organ failure, and on 4th day he received dexamethasone. Initially, a patient got admitted for 5 days. Patient received dexamethasone.
Rupa, whether you are satisfied or not, you can put in the chat box. And another question by Ajay Raghav Joshi. Why was eschar, when you found the eschar, why was eschar ignored? Because IgM scrub typhus has a very poor sensitivity.
We have sent the sample for IgM, and we have also given azithromycin for noted the ester and suspecting it to be a case of scrub. We have given both ceftriaxone and azithromycin both.
So Rupa, are you happy? And Ajay, are you happy?
But we have repeated actually 2 times, and both times it was came negative.
Okay. So it is almost a clinical diagnosis. So if you suspect, you can give, because at this time, at this juncture, I have got 5 cases of this scrub typhus in my hospital. 5 cases. So this is the scenario of West Bengal also, here in your hospital also. So excellent case. I must thank, you can stop sharing. I must congratulate the team Midnapur Medical College under the able guidance of Professor Tarapada Datta. I am giving you very good news that the 2 presenter will get first and the second prize, and it will reach the mentor Professor Tarapada Ghosh within 1 week. And this certificate will be relevant in your MD exam because 10 marks are there. Probably you are aware of that. And as a state almost a body, so you are entitled to get the 10 marks. So it will reach in time. Please forgive me if I am late for just 1 or 2 days. I will try to make it possible within this week only. Within 7 days, you will get the prize, because we don't want to discriminate. But the thing is that it will help you in your exam. That's why we have started this certificate, who is the first prize winner and who is the second prize winner. And this certificate will definitely help. So can we, you have got anything to say? Because I can see the principal madam sitting behind you.
Thank you, Shapon, for conducting this. And from Midnapur Medical College, many investigations have been done, but also there is Dr. Lal's lab and Lal's pathology, and they also do the sophisticated tests.
You can stop sharing. You can stop sharing so that we can see each and every one of you. Stop. So you can stop sharing your screen.
Hello.
Hello. Tarapada, you want to say something?
Whether I'm asking whether all participants should get a participant certificate.
You are not audible. You are not audible.
Now, all the participants will get participation certificate.
Participation certificate we can send if you want, but the thing is that
Yes.
it won't help in their exam.
That is not for
won't
that.
help in their exam.
It will help, and also the first and second.
Okay. Okay, done. So Tarapada, you want to say before we conclude? So thanks again all the participants and the audience who have logged in.
And also we have Dr. P.C. Mondal, Lasho, our who is the president of Midnapur Society of Pediatrics.
Okay, but here we are not going in that particular fashion. We are concentrating on the medical college only. So I must thank Dr. P.C. Mondal also, because all throughout the session he was there. So thank you. And I must congratulate the Midnapur Medical College, even after the puja and the lot of problems, that you have showcased your talents. And I must congratulate Dr. Tarapada, Professor Tarapada Ghosh also, with the able guidance.
The cases were being prepared from before puja only.
Okay, thank you.
Okay. So again, we will see you in the next meeting. Bye-bye. Somnath, you can stop.
ঠিক আছে, খুব ভালো হয়েছে।
আসলে সাজিয়েছে ভালো।